Let's talk about calcium. That little mineral that spends most of its time in your bones, but has a say in everything from how your heart beats to how your muscles twitch. It's one of those Goldilocks things in medicine. Too little and you've got trouble, too much and you've also got trouble. The body likes it just right, somewhere between 8.6 and 10.4 milligrams per deciliter in the blood. And your body is picky. Even small swings outside that range can cause big problems. Now, calcium isn't acting alone. It's in a complicated relationship with parathyroid hormone, calcitonin, vitamin D, and its frenemy phosphorus. If calcium's up, phosphorus usually takes the elevator down, and vice versa. Part 1. When calcium is too low. Hypocalcemia. If your patient's serum calcium dips below 8.6, the nerves and muscles get cranky. Calcium normally helps keep nerve signals smooth and controlled. Without enough, the nerve membranes get hyperexcitable. They start firing off signals like an over-caffeinated telemarketer. Causes. Hypocalcemia can happen for a lot of reasons. Hypoparathyroidism, vitamin D deficiency, chronic kidney disease, pancreatitis, hypomagnesemia, massive transfusions with citrated blood, certain meds like loop diuretics and anticonvulsants, or from high phosphorus levels. What it looks like. Your patient might complain of tingling around their mouth or in their fingertips. They may have muscle cramps, hyperactive reflexes, or, in more dramatic cases, laryngospasm, bronchospasm, or seizures. Classic bedside tests: Chvostek sign. Tap the facial nerve, and if the face twitches, that's a positive sign. Trousseau's sign. Inflate the blood pressure cuff and watch for that carpal spasm. On the monitor, you'll see a prolonged QT interval. Medical management. Acute, symptomatic hypocalcemia is a 911 situation. You'll be giving intravenous calcium, usually calcium gluconate or calcium chloride. No sodium chloride solutions. They make the kidneys dump more calcium. Don't mix with phosphates or bicarbonate. They'll form crystals and clog your IV line faster than a bad milkshake. Give it slowly through a pump with the patient in bed. Too fast, and you risk bradycardia or cardiac arrest. If your patient's also low on magnesium, fix that first. Otherwise, your calcium replacement may flop. Nutritional support. Vitamin D helps the gut absorb calcium. In chronic kidney disease, you may need to lower phosphorus first with things like aluminum hydroxide or calcium acetate before calcium therapy works. Teach patients to aim for 1,000 to 1,500 milligrams a day, divided into doses no larger than 500 milligrams. Why divided? Because the gut is a diva. It won't absorb more than about 500 milligrams at a time. Good sources: milk products, green leafy vegetables, canned salmon or sardines, fresh oysters. Teach them what not to do. Avoid too much alcohol, caffeine, smoking, or phosphorus-heavy laxatives. All of those push calcium out of the system. Nursing management. Seizure precautions for severe cases. Monitor airway closely for laryngospasm. Keep safety in mind if confusion is present. Patient education on diet and supplements. Watch for digitalis toxicity if they're on it. Part 2. When calcium is too high, hypercalcemia. On the flip side, if calcium creeps over 10.4, you're looking at hypercalcemia. Mild elevations can go unnoticed, but higher levels slow everything down: muscles, gut, brain. One of the biggest dangers, a hypercalcemic crisis. Left untreated, it can stop the heart. Causes. The big two. Malignancies, like breast, lung, renal cancers, multiple myeloma. Hyperparathyroidism. Others include prolonged immobility, thiazide diuretics, vitamin A or D intoxication, lithium or theophylline toxicity. What it looks like: weakness and incoordination, anorexia, constipation, abdominal pain, severe thirst and polyuria, lethargy, confusion, even coma. Bone pain. On ECG, you'll see a shortened QT and ST segment, maybe a prolonged PR. And remember, high calcium makes digitalis toxicity more likely. Medical management. Step 1, treat the cause. If it's cancer, address the cancer. If it's overactive parathyroid glands, surgery may be needed. Meanwhile, increase mobility. Bone needs weight bearing to keep calcium where it belongs. Stop calcium intake, both from diet and meds. Hydrate with 0.9% sodium chloride to dilute serum calcium and boost kidney excretion. Add furosemide to help the kidneys dump calcium. For certain patients, calcitonin can lower calcium by pushing it into bone and increasing urinary loss. Corticosteroids help in sarcoidosis, myelomas, lymphomas. Bisphosphonates like pamidronate or ibandronate stop bone breakdown. Mithramycin is a last resort. It works, but it's toxic. IV phosphate drops calcium quickly but can cause severe tissue calcification and kidney injury if not done carefully. Nursing management. Monitor at-risk patients. Encourage 3 to 4 quarts of oral fluids daily, preferably with sodium if not contraindicated. Get patients up and moving early. Add fiber to fight constipation. Watch for arrhythmias and digitalis toxicity. Reassure families that mental status changes can be reversed with treatment. Quick side-by-side. Hypocalcemia, twitchy nerves, prolonged QT, positive Chvostek and Trousseau signs, seizure risk. Hypercalcemia, sluggish muscles, shortened QT, constipation, risk of cardiac arrest. Both require quick recognition and targeted treatment, and in both, your job as the nurse is to monitor, educate, and act fast when something changes. Calcium may seem like just a number on a lab sheet, but when it swings too far in either direction, the effects are head to toe. It's our job to keep that number in the just right zone and recognize when it's wandering off. Because with calcium, like Goldilocks, the middle ground really is where the magic happens.